So my challenge is to talk about innovation in health systems and how innovation can produce good health but also economic growth. Necessarily, this is a huge subject. And I spent quite a few weeks thinking about what is the key message that I want to leave behind. And there's one message which I want you to remember at the end of my session, and that is asymmetric innovation. I will elaborate on this, and I'll try and illustrate this concept of asymmetric innovation, why it's a major challenge for health systems globally, but specifically for France, which has been a high-performing health system. So I will initially, very briefly, visit the evidence on innovation, health, and economic growth. Then I will focus on asymmetric innovation, why this is a very, very important challenge, and that began to emerge in the discussion, earlier discussion today. Third, visit the French health system. Look at the successes, but the challenges the French health system faces. And finally, what France could do to lead the world in addressing asymmetric innovation to create an appropriate ecosystem. So health, economic growth, and sustainable development. Now, this is a well-rehearsed area, so I'm not going to go into great detail. In fact, at Harvard, there was a very healthy discussion between Philippe Aguillon in the economics department, but also my colleagues David Canning and David Bloom, who argued, does wealth produce health? Or is there two-way relationship? Health also produces wealth. And also Darren Ajamolu from MIT entered this debate, and they were talking about the reverse causality. But I think the evidence is compelling to show that not only does wealth produce health, but also health does produce wealth through economic growth and then contributes to economic development. And the cycle, and this is from a paper we did recently for the Ministerial Leadership Program at Harvard, for which I'm the faculty chair with my colleague Donald Keberuka, who was the president of the African Development Bank. We reviewed the literature to try and convince the ministers of finance to invest in health, but we had to make an economic case for them. So we briefly reviewed the evidence to show that good health does reduce morbidity and also mortality, which then reduced morbidity improves productivity, as Philippe Aguillon said today, but also ensures presenteeism. People go to work when they're healthy. When they're not healthy, they don't go to work. Also, there is, very importantly for France, there is less loss of human capital. This is avoidable mortality. With well-functioning health system that produce good health, people at productive ages do not die early at the peak of their know-how. And then this helps to produce economic growth and sustainable development through 6 channels. One is the human capital, as I mentioned. Secondly, the productivity of this human capital. The third is the demographic dividend, where a well-educated population with employment opportunities does increase production. Fourth is education. Individuals who believe that they're going to be healthy, they invest in education. Undergraduate, postgraduate, skills development, lifelong learning. Fifth is financial protection. Individuals who are protected in health, protected from excessive expenditures, do not incur catastrophic expenditures or fall into poverty. So they're able to engage in their work. And finally, capital investment. Those individuals who believe that they're going to have good health, they invest their future by investing in pensions. Then the funding from pensions can be used to invest in the economy. And all of these interact to produce economic growth. Indeed, innovation does help. So if we look at the evidence, this is from World Health Report 1999, which is one of the best reports WHO produced. They looked at the contribution of wealth, i.e. economic growth, but also other important structural interventions such as education of girls, and how these, between 1952 and 1992, led to improved outcomes in health as measured by under 5 mortality, adult mortality for women and men. And they were able to conclude that almost 1/2 of the improvements experienced between 1952 and 1992 resulted from access to new technologies and knowledge. That's innovation. It's a bit like the solo residual that Philippe Aghion was talking about today, that it's not just factor growth or increase in labor, but actually application of knowledge is quite critical, and that's important for our discussions. And this work has been taken forward by a number of scholars, including David Cutler at Harvard, who was able to demonstrate that sustained improvements in health depend on uptake and diffusion of innovations. Now, that's very important. So there is the production of innovation, what I call delivery of the innovation, but also the uptake and diffusion. And that is innovation and delivery to ensure that these innovations are taken up. If they're not taken up, then we're not going to have the outcomes or improvements in health. Now, that's something, an important principle I will come back to. But specifically looking at pharmaceutical innovations, Lichtenberg from Columbia University has been able to demonstrate that pharmaceutical innovation also contributes to mortality reduction and growth in lifetime per capita income in the 2 periods he studied, 1970 to 80 and 1980 to 91. And he was able to show significant positive relationship across different conditions where new and priority drugs were introduced and when these innovative drugs were taken up. And he was able to compute or estimate that new drugs increased life expectancy and lifetime income by about 0.75 to 1% per year, which at aggregate is actually quite an important sum. But we have a challenge. We have the challenge of asymmetric innovation. This is Degas, and you might wonder, why do I have a picture of Degas? Well, because I had to find a French painter, and someone who was famous that everyone would know, and someone that I could also recognize. Well, Degas is interesting because, as one of the Impressionists, he emphasized asymmetry in his paintings, although not so subtle and obvious, but he was one of the leaders in the development of the school where that focused not on symmetry, but actually asymmetry. Now, the asymmetry in health systems is that, and this is a statement directly from an article I did for the Financial Times in December this year, that scientific developments, as we heard today, have spurred unprecedented delivery of innovations in molecular biology, in targeted therapies, biotechnology, but also in information and analytics for new medicines and medical devices. But innovation and delivery has faltered. So we're producing lots of innovation, but the delivery system is not changing so that these innovations are not being taken up. And to achieve good health and to realize economic benefits, the uptake and diffusion of innovations is critical. And again, in this article, I concluded that the intensity of scientific discovery due to convergence of many sciences has far outstripped the pedestrian pace of innovation in healthcare delivery, where the models hark back to 20th century, even earlier. So let me have a look at some innovations that are coming through. The list is very long, so I think immunotherapy is very exciting because it gets us into precision medicine. There is bionic sight, field-constrained surgery, but one could spend days talking about the new innovations that are coming through. But if we look at innovation and delivery, I thought again I would use a French example. Hôtel Dieu de Paris. It is reputedly the oldest hospital in the world. It's still functioning, which is great. It was established by Saint Landry in 651. I don't think my great-great-great-great-grandparents were alive then. And I did my postgraduate training. I trained in England. And I did my postgraduate training at St. Bartholomew's Hospital, London, which was founded much later, so French were leading, in 1123 by Rahier. In one of these rooms, my senior colleague would proudly say, this room goes back to the 12th century. Then I used to ponder, nothing has changed since. So the problem is we're stuck with models that go back centuries. Now, hospitals were built for binary outcomes. So a person came in, often with an infection. They either survived or they died. Now, the context is very different. When I have chronic illness, the large proportion of the population will have 1, 2, 3, or 4 chronic illnesses, plus disability, which I'll come back to. One cannot treat one's way out of this chronic illness in hospitals. And also the model of primary, secondary, tertiary care, that goes back to 1920. That was an administrative construct developed by Lord Dawson in his report to the British Parliament to think about how best to administer the health system. But we're stuck with these rigid models in terms of delivery. So innovation and delivery is lagging behind by a few centuries. Again, going back to Degas, the asymmetry is really quite concerning. So there's also an asymmetry, not just between the scientific innovation and lack of innovation in delivery, there's also an asymmetry in the innovation in policy and policy environment. On the one hand, industrial policy, especially in the context of European Union, for example, industrial policies encourage innovation to produce more innovation and a technology push. But health policies, on the whole, constrain innovation, adoption, and diffusion because there are limited rewards for downstream innovation to take it up. In fact, it's very difficult to innovate. I worked as a physician in England, and I was an innovator, and I had some flexibility. But I remember once we were trying to discuss whether to use pregnancy test, near-patient testing, or sending this to a hospital, which would require a patient to come in the morning to provide an early urine sample. Then that would have to be collected. Then someone would come and collect that, take it to a hospital. Then I would get a result 2 weeks later or a week later. And then I'd have to call the patient back because of confidentiality. And the whole process we mapped out, there were 40 steps. But I could do that just in one step. Then after 18 months of discussion in committees to try and introduce this innovation, what was the outcome, do you think? The outcome was, oops. Are you okay? Okay, well, I hope it wasn't me. I know I can be challenging at times, but I hope she's okay. I'm very sorry to see that she's ill. So we spent almost 18 months in committees, and outcome was to stay with the old model. Even though it was more costly, it was not better for the patients, it delayed everything. So health policies constrain innovation, adoption, and diffusion. There's also silo mentality. We don't look at the system as a whole. Often, we focus on segments of the budget. And typically, this will be budget for medicines or medical devices, which account for, together in OECD countries, about 20% of the total expenditure. And this is an area where we can measure. And we look for short-term efficiency gains rather than looking for long-term benefits of introducing innovation. And also, the system effects of constrained innovation adoption is not explored. Focuses very much on rationing innovation as opposed to looking at what might be the consequences of rationing innovation. Asymmetric innovation has very important consequences. And there are a number of studies that have explored why it's so difficult to introduce innovations in health systems by my colleague Reggie Hersling at Harvard Business School. And I've done quite a lot of work on this, looking at barriers to introducing innovations in health systems in different countries. And where innovations in delivery are lagging, as it is in the US, almost $1 trillion of health expenditure in the US is wasted. That's just about the GDP of France. I think GDP of France is about 1 point, for the macroeconomists in the audience. It is about probably 1.5 trillion, I would suspect. But this is huge waste. 2 trillion, yes. So again, a very large sum. So 1 trillion, very large sum. And this is wasted because there's been limited changes in the way care is delivered in the US context. But change is difficult, as Machiavelli said in his book, The Prince, in 1513. There's nothing more difficult to plan, more doubtful of success, nor more dangerous to manage than the creation of a new order of things. So disrupting this structural environment that has been established over hundreds of years is very difficult. So that's one important barrier. Second important barrier is actually politicians. And this is important in the age of untruth, with the new president we've elected in the US. The political will for use of evidence and transformative change is lacking because, as John Maynard Keynes said, there's nothing a government hates more than to be well-informed. It makes the process of arriving at decisions much more complicated and difficult. As a result, we have very little evidence on this 80% of the expenditure on the delivery side to understand the efficiency and effectiveness of what this rump of the system is doing. And politicians, they don't want to introduce change because they want to be re-elected. And typically the election cycle is 3, 4, 5 years. And the lifetime of a Minister of Health is typically 12 to 24 months on average. So that's another challenge. So let's look at the French health system. Is French health system also experiencing asymmetric innovation? What has it achieved, and what are the challenges it faces? Well, I think you can be very proud. French system is one of the high-performing health systems, or was. In fact, in 2000, the World Health Report ranked France as #1. I will not go into the discussions on the methodology of the comparative health systems analysis, because at the time, many of us were involved in the critique. And comparative health system analysis is a dangerous sport. It's not for the amateurs. But nonetheless, we do have some metrics that we can use to get a feel of how countries are performing. On the whole, French system does well in relation to health status. So this is France. So anything above the line is high performing. This is health spending per person. So in terms of life expectancy in years, France is in the same pack as many other countries, but not as good as countries like Spain that spent almost sort of one third. So it's performing, but not the best performer. So good outcomes in relation to health status, very good financial risk protection, excellent. And also, citizens are quite satisfied. So there are very important features of the system that should be maintained and built upon. In relation to health system objectives, these are the metrics we look at when we compare health systems. As I said, in terms of equity, France does very well. In terms of responsiveness to users, the French system is also quite responsive. But in relation to efficiency and effectiveness, I think the system is underperforming relative to what other countries are achieving. So let's try and explore this in more detail. So in relation to effectiveness, this is using evidence-based interventions to improve outcomes. If we look at potential years of life lost, so these are avoidable mortality. Everyone will die. John Maynard Keynes once said, in the long run, we're all dead. But we can avoid early mortality, yes, by health system interventions. Here, compared to Germany, Netherlands, Switzerland, Sweden, and Norway, this is France, this is women. French women do relatively well, but not top of the pack. But it's the French men who are doing very badly, I'm very sorry to say. Who are the men in the audience? Those who are alive? We're the weaker sex, of course. and Frenchmen seem to be not doing terribly well. If we look at avoidable mortality, potential years of life lost, France is doing worse than all the other countries. And although there's some convergence in the higher performing countries, France has not caught up with that convergence. So we're beginning to see a system that's coming under stress in relation to improving outcomes. If we look at the efficiency by which the care is delivered, my conclusion, reading all the available documents on the French health system, leads me to conclude that French health system is very biomedical in its orientation. It's very hospital-centric. If we look at hospital beds per 1,000 population, France is in top of the pack. And the levels are twofold. It's not just a marginal difference. And it's only Germany that outstrips, and Austria, that's in terms of countries of similar income. So high number of hospital beds per 1,000 population, but also high utilization of these beds. So this is also a cause for high level of expenditure. Now, in terms of pharmaceutical expenditures, actually as a proportion of total expenditure, these have increased to around 17%, but then declined and have been steady at around 15%. And medical devices account for 5 to 7%. So that's not high if we think of the total expenditure and given the benefits of these new technologies. Although medicines and new technologies are beneficial, in France, their uptake is slow. If we look at, this is a study done by the Australian government, who were looking at how quickly innovations were introduced in the Australian health system, and they compared about 15 to 20 countries. And this looks at the uptake of innovations, proportion of new medicines, reimbursed, proportion that are registered and also reimbursed. In France, that's about 50%. So many drugs are registered, but they're not reimbursed. If we look at the time taken for new medicines from registration to reimbursement of those that are reimbursed, France, it takes about 375 days, which is far slower than, say, Japan, Germany, Austria, where it takes about 100 days. So not all innovations are adopted, and when they are, it takes a long time. So there's a loss of the benefit of these innovations in the system that produces improved health outcomes. But going forward, and this is what we should be doing, not looking at the past, but looking at the future, what's going to happen in the French health system? And there are some very interesting findings. First is the demographic change. Aging, which brings physical disability. It took France almost 150 years to double the proportion of those aged 60 years, from 10% of the total population to 20%. So from 1850 to 1995, that doubling took just under 150 years, 145 years. And over the last few days, I was trying to estimate how long it's going to take to double from 1995 the over 65 population, those aged 65 and more, in the future. And using United Nations Population Division projections, the medium variant, I was able to sort of estimate that in 1995, there were about 9 million people in France who were aged 65 or more. And it will take around 35 to 40 years for this population to double. Now, we're already in 2017. Now, the implications of this aging is quite significant, this very rapid aging, because it brings an epidemiological transition to chronic illness. But more importantly, we have multimorbidity. Why is multimorbidity important? Because multimorbidity, having one or more, two or more chronic conditions, leads to very high levels of utilization. So we analyzed a few years ago 6 upper middle income countries that included China and India to look at utilization patterns of those without chronic illness, 1 chronic illness, or 2 chronic illness, which is the definition of multimorbidity. And outpatient visits using no chronic illness as our index, as a reference point. In those that have 2 chronic illnesses, utilization of outpatients increased 3-fold. Inpatient admissions also increased 3-fold. But length of stay in hospitals compared to our reference increased 3.5 times. So multimorbidity leads to rapid utilization. Then we went on to analyze what happens when someone has 3 or 4 conditions. And compared to someone that has 1 chronic illness, an individual, and this is using Estonian data, this is a country that's further down the transition, the hospital inpatient admissions, the odds of being admitted, is 20 times more. So this transition has massive implications for the French health system. Of course, citizens expect, especially with the elections coming up, a responsive health system. Economic conditions are not favorable. There are fiscal space constraints, and technology is constrained. So this is a perfect storm of all of these transitions happening very quickly and coming together to impact on the health system. So not changing is not an option. It has to happen. Otherwise, the system will come under crisis. Although in 2000, the French health system was ranked #1, in 2003, there was a heat wave in Paris. And almost 15,000 people died, many of them elderly. And I was reading on the news that the system is under stress because of a flu epidemic. And hospitals are full, emergency services are being stretched. So we're beginning to see stress signals on the system, which in the future, and the future is here, is going to be constrained even more. So going forward, and I have just a couple of slides, and I'll finish. So we need to invest, we need to generate more money for the health system. Where will the money come from? How can we create more fiscal space? Well, economic growth is not likely to be very high, so that's not an option. Reproduction of health in the government budget, ministers will fight. Broaden tax base, well, I think there's good opportunity from tobacco tax because France has very high levels of tobacco smoking, and maybe a sugar tax, there's a possibility. Borrowing, not an option. France is already highly indebted. Well, but one can improve the effectiveness and efficiency of the health expenditures by effective budget allocation and more health system efficiency, by addressing this asymmetry of innovation and improving the innovation and delivery of services. But how can that happen? Well, we need to rethink about the health system. The funding of health systems in the past was very much based on the structures. There was a structural focus. So there was historic budgeting with budgets allocated to hospitals or primary care centers. So payment followed the structures based on historical precedents. Then we transitioned to what I call a functional focus. And this is where the French system is now, where payment follows activity. Disease-related groups or fee-for-service, for services being delivered, and mostly in the hospital setting. That's inflationary. It also rewards part of the care. It doesn't reward outcomes. So a person may do well in hospital, but when they're discharged, they may not survive. And we can see high levels of avoidable mortality or avoidable life for years lost. So we need to transition to a new model, so-called the value focus, where payment follows outcomes. Now, how organizations or networks achieve these outcomes is up to them. It creates an environment for micro-innovation to improve and to innovate, to come up with new delivery models, to focus on analytics, focus on communication, IT, and new medicines. And at an individual level, one can fund outcomes by grouping patients or persons according to their risk, so-called risk-stratified bundled care. And payment can follow if outcomes are achieved during an episode, in 30 days, 60 days, 90 days, or 1 year, but to focus on outcomes. And then that can be in aggregate translated to population level. So institutions, networks are rewarded for achieving outcomes, improving outcomes. So there is an incentive to innovate. So going forward, to address the asymmetric innovation, we need to have not just push strategies that encourage innovation push to the system. We need research and development. But we also need pull strategies to create demand, to signal that innovations should and will be adopted, with enabling policies that will accelerate access to new technologies, new medicines, but also innovative care delivery models by transitioning to value-based healthcare and by institutional transformation. So ladies and gentlemen, distinguished colleagues, it's been a real honor and privilege to speak here. The French system has been a high-performing health system, but I think in the future it faces challenges. And asymmetric innovation is very obvious. Future is here, and I think we need to act now. Thank you very much.